Okay, so I developed some questions here to see if you as neonatologists might be a Kindlefresser. So question number one is, and I'm not asking you to raise your hands here, I'm just asking you the questions, okay? I don't want to embarrass anybody. But do you start amino acids slowly and advance over a period of a week to about 3 grams per kilogram per day when giving total parenteral nutrition to a premature baby? Second question, is a 1 kilogram baby, such as this baby seen in this slide, receiving adequate caloric intake for growth if this baby is on TPN, not getting any enteral feeding, if this baby is getting 3 grams per kilogram per day of amino acid, 8 milligrams per kilogram per minute of glucose, and 1 gram per kilo per day of intravenous lipid? More questions. In a 1 kilogram baby, do you hold enteral feedings for a week, then begin enteral feedings very slowly? And last question, is a 1 kilogram preterm infant receiving adequate DHA, docosahexaenoic acid, when receiving TPN with 3 grams per kilo per day of intralipid, assuming this baby is not getting any enteral feedings? So if you answered yes to these questions, you are probably a Kindlefresser. So what is common practice in many neonatal intensive care units? We delay enteral feedings, sometimes for long periods of time, 1 to 2 weeks. We introduce total parenteral nutrition gradually over a period of 1 to 2 weeks. And this is at a time when the infant is also highly stressed and highly vulnerable to nutritional deficiencies. I think we have to look at nutrition in our preterm babies as an emergency, very similar to the way that we look at airway management and giving surfactant and giving pharmacologic agents early to these babies. Nutrition early on is very, very important. Why do I say this? Because if you look at the body composition of very preterm babies, here is a weight of a baby at 24, 26 weeks gestation. Here is the water content. These babies are almost like a little bag of water with very little protein, very little lipid, and you can see this is less than 1% body fat in a 24-week gestation premature and 1.5% body fat in a 26-week premature. And the caloric stores, the energy stores in these babies is very minimal. Assuming that it requires somewhere between 100 to 120 calories per kilo per day to nourish a baby like this, to keep a baby like this alive, this baby at 26 weeks gestation would utilize all of its energy stores within the first 24 hours. The brain development is very important in these babies. And when you look at an MRI of a baby born at 25 weeks gestation, we see this kind of a picture. And at term, we see this picture. There is a tremendous amount of brain development that occurs during this very short period of time in the last trimester of pregnancy. So you can imagine what will happen if you interrupt good nutrition during this period of time. And this is what we commonly do in these very low birth weight babies. I'd like to just show you some data from a study that was done at Brown University by Dr. Betty Boer's group, and they do a lot of very nice follow-up studies. And this was a retrospective study of 128 extremely low birth weight babies, looking at these babies at 18 months of age. And the question that was asked by this study is, what happens when you undernourish these babies, or what happens at different nutritional levels in these babies in terms of their neurodevelopment at 18 months of age. So here on the y-axis, we see the mental development index at 18 months, and here we see the first week amino acid intake. And when we look at the amino acid intake in this first week, we see that here we have an increment of 1 gram per kilo per day. And I'm sorry that this is off, but what you see here is an increment of 8.2 IQ points for every 1 gram per kilo per day increase in amino acid intake. So if you are giving these babies 2 grams per kilo per day compared to 1 gram per kilo per day of amino acid, in the first week, at 18 months, you will see an 8.2 increment in MDI or IQ in these babies. If you look at the caloric intake, a 10 calorie per kilo per day increment in caloric intake will result in a 4.6 point increment in MDI or IQ. So if you are giving these babies suboptimal energy or suboptimal amino acid protein intake, you will be causing these babies to have deficiencies in their IQ at 18 months. So this is telling us that this first week is extremely important. Now, I'm going to mainly focus on the enteral nutrition of these babies, and then Dr. Hay will focus more on the parenteral nutrition. But what are some of the concerns that we have with enteral nutrition in these babies? Well, the neonatologist is scared to death of this disease, and I'll talk about this a little bit more later. This is a baby with a severely distended abdomen who has a necrotizing enterocolitis, who is perforated, and a baby like this is very highly likely to die of the disease. And so we have a lot of fear of necrotizing enterocolitis, and because of this fear of necrotizing enterocolitis, we are sometimes afraid to use the gastrointestinal tract liberally in these babies. So neonatologists tend to use a lot of excuses not to use the gastrointestinal tract in these babies. And some of these excuses are seen on this slide. Low Apgar scores. Baby has an Apgar score of 3 and 6. We're not going to feed this baby for several days because this baby had an Apgar score of 3 and 6. Umbilical artery catheters. I think a lot of neonatal intensive care units are now ignoring the fact that umbilical artery catheters are in place and feeding babies if they have umbilical artery catheters. The concern at one point was that these umbilical artery catheters shoot little thrombi to the gastrointestinal tract and cause damage to the gastrointestinal tract, and that leads to necrotizing enterocolitis. That has never been proven. In fact, studies have been done to look at that and have disproven that. Other issues, if baby is having respiratory problems such as apnea and bradycardia, baby is on mechanical ventilation or CPAP, many neonatologists use that as an excuse, and that has not been shown to be a reason to not use the gastrointestinal tract in these babies. The use of vasoactive drugs. It's very common if a baby is getting indomethacin to stop feedings. In fact, in the state of New York, in the United States, in the state of New York, there are guidelines that neonatologists are provided by the Neonatology Society to not feed babies while they are being given indomethacin. And you'll see a little bit later that that may be the absolute wrong thing to do as I show you some data. And we also know that TPN is available. We can nurse these babies using TPN, and we know that they can grow quite well on TPN, so we use this excuse that TPN is just fine, we can get these babies to grow, and that giving full TPN is benign without using the gastrointestinal tract. That is wrong, and we'll get into that also. Now, I want to just mention a little bit about the gastrointestinal tract, and it's very important for neonatologists to remember that a premature baby has a gastrointestinal tract, okay? And you can actually use this gastrointestinal tract in these babies. And the gastrointestinal tract is a highly versatile organ. It is not just meant to be a digestive, absorptive organ. It's also the largest immune organ of the body. It harbors a huge microbial ecosystem, and over the last 10 years, we are beginning to find out the importance of this microbial ecosystem, and we are beginning to think that the microbes in our GI tract are another organ system of the body, an extremely important organ system of the body. It harbors the enteric nervous system, and the enteric nervous system, the number of nerves in our gastrointestinal tract equal the number of nerves in our entire spinal cord. So this organ has tremendous versatility and a lot going on in it. Now, what I want to talk about, at least at the beginning here, is some developmental anatomy, some physiology, and clinical applications related to this physiology. I'm going to initially talk about intestinal growth, swallowing, GE sphincter function, gastric emptying, intestinal motility, then talk a little bit about digestion, absorption, and assimilation, because those are different processes. Some considerations of innate immunity, especially the gastrointestinal barrier, and try to talk about clinical implications of all of these. Now, what about growth of the gastrointestinal tract? The human fetal intestine elongates 1,000-fold from 5 to 40 weeks gestation. The length doubles in the last 15 weeks of gestation, and the length of the entire intestinal tract is somewhere between 250 and 300 centimeters at term. The surface area of the gastrointestinal tract is huge. And when we think about the surface area, it's not just the villus surface area, but in the tips of the villi. If you look at the tips of the villus epithelial cells, you see these microvilli, which provide a huge surface area. The surface area of an adult skin is approximately 1.6 square centimeters. And the surface area of the intestine is approximately 200 square meters, okay? So skin, 1.6 square meters. The intestinal tract is 200 square meters. So a huge, huge surface area, the largest surface area of the body. It approximates the size of a tennis court. Now, in fetal life, the fetus actually has a very active gastrointestinal tract, and the fetus swallows approximately 450 milliliters per day of amniotic fluid during the 3rd trimester. So there's a lot of activity going on in the fetal gastrointestinal tract during this last trimester. But this is generally stopped right after birth because we do not put very much food into the gastrointestinal tract. Can you imagine trying to put 450 milliliters of milk into a baby's gastrointestinal tract who weighs 1 kilogram in the first couple days of life? Baby probably would not tolerate it, and this would be a major problem. But in fetal life, amniotic fluid is very well tolerated. Now, some of the physiologic processes I'd like to cover are first, gastroesophageal reflux. And when we talk about gastroesophageal reflux, we are generally talking about an entity that is seen very commonly in premature babies. In fact, the majority of premature babies have some form of gastroesophageal reflux. But is this gastroesophageal reflux disease, is this actually a pathologic process? There is a big difference between gastroesophageal reflux, which is just a normal physiologic process, and gastroesophageal reflux disease. When we talk about gastroesophageal reflux disease, we are talking about an entity where the baby would actually have a problem with gastroesophageal reflux, where that baby would be aspirating the gastric contents, or where the baby would not be growing well, or where the baby would actually be showing signs of inflammation of the esophagus, esophagitis. Most of the babies that we take care of, either we don't look for those things or don't have those problems. Are clinical signs reliable in the diagnosis of gastroesophageal reflux or gastroesophageal reflux disease? Very often when I go on rounds with our team, I find that the nursing staff says on a particular baby, this baby is definitely showing signs of reflux. We've got to treat this baby with drugs. We've got to do something to treat this baby because this baby is showing signs of gastroesophageal reflux. Do you find that in your units? Probably, okay. Well, there's been some studies to look at this. And this is one study that was done a little bit over 10 years ago. And the purpose of this study was to determine if looking at babies and babies showing signs of gastroesophageal reflux, if they actually had acid reflux from their stomach. So what they did was they placed tubes for measurement of acid reflux into the stomachs and the esophagus of a large number of babies, 20 babies, and they also recorded the behavior of these babies for a long period of time, and then they showed films of these babies to nurses and to physicians. And the nurses and physicians all seemed to agree that there was a fairly high degree of inter-observer agreement that these babies were having signs of gastroesophageal reflux. These babies were coughing, gagging, head retraction, etc. But then when they looked at the actual pattern of gastroesophageal reflux or acid reflux and the behavior of these babies, there was no correlation. So that suggested that what we are seeing in the neonatal intensive care unit, that things that look like it might be gastroesophageal reflux, like coughing and gagging, might not actually be true gastroesophageal reflux. Now, what's the main problem that we attribute to gastroesophageal reflux in premature babies? Well, it's not so much vomiting or esophagitis or inflammation or babies who are aspirating their gastric contents. We are concerned that these babies are having apnea due to gastroesophageal reflux. And here are a couple of review articles. In fact, Richard Martin wrote one of these articles. And the bottom line in these articles is that there's a strong physiologic evidence that stimulation of laryngeal afferents elicits central apnea and laryngeal adduction. But overall, gastroesophageal reflux and apnea do not appear temporally related in these preterm infants. And in fact, apnea precedes reflux more often than reflux precedes apnea. In other words, it's not the reflux that causes these babies to have the apnea. It's oftentimes the apnea that causes these babies to have the reflux. Another very interesting article, and I don't know how many of you use drugs in the treatment or prophylaxis of reflux, but I know that in our neonatal intensive care unit about 6-7 years ago, many of our preterm babies were getting prophylactic metoclopramide and ranitidine for the prophylaxis of reflux. What does the data show? In infants with bradycardia attributed to gastroesophageal reflux disease, preterm infants had more bradycardia when receiving these reflux medications than when receiving placebo. And the reason for that is that histamine receptors are present in the heart, and ranitidine is known to cause bradyarrhythmias. So I think that what we are beginning to do is to be a little bit more respectful of these drugs and the use of these drugs, and we are using less of these drugs than ever before in the prophylaxis of apnea and bradycardia. There are some simple things that we can do for the treatment of reflux. If you're thinking that a baby may have reflux, simple positioning may be very helpful. And this is a study from Italy. Dr. Caviglia did this study and reported this in Pediatrics in 2007. The left side down position shows the lowest esophageal acid exposure in the early postprandial period, and the prone position shows the lowest esophageal acid exposure in the late postprandial period. So the conclusion to this is, after feeding a baby, if you want to prevent the reflux, right after feeding the baby, you put the baby on the left side for a period of time, and then after an hour or so, if you want to prevent the reflux, you can put the baby in the prone position. And this is one way to very simply help prevent gastroesophageal reflux. Now let's go down the gastrointestinal tract a little bit further and think about feeding intolerance. And a lot of babies retain their food in the stomach for long periods of time. And one way to try to get rid of that food in the stomach, or to increase the propulsion of food through the stomach, is to use the drug erythromycin. Now, at this juncture, there are at least 10 randomized controlled trials in preterm infants. And I refer you to this review article by Dr. P.C. Ng from Hong Kong. And he reviewed these 10 randomized controlled trials, and he found that when used for rescue, erythromycin was associated with a shorter time to attain full enteral feeding, and that the higher doses of erythromycin, 12.5 milligrams per kilogram given every 6 hours through the oral route, reduced the incidence of parenteral nutrition-acquired cholestasis by almost 50%, and also improved the amount of feeding intolerance in these babies. And so he summarized in this review article that the current information favors the use of rescue rather than prophylactic treatment. In other words, don't use this on all babies. But if you have a baby that you try several tricks, in other words, the kind of tricks that you can sometimes use is provision of longer periods of feeding, using pump feeding for an hour to 2 hours, which actually is known to increase the gastric emptying capability of the stomach. You try that trick, for example. You make sure that you're not giving a high-fat diet to these babies, which prevents gastric emptying. But if you try all of those tricks and the baby is still having a lot of feeding intolerance, it is probably worthwhile to at least give a couple of days of erythromycin, and after 2 to 3 days, if you are seeing a response, then keep the baby on the erythromycin for a couple of weeks, but stop the erythromycin after those couple of weeks, and to see if the baby is then able to tolerate the enteral feedings better. Okay? But do not use the erythromycin prophylactically. There are some studies that suggest an increased incidence of pyloric stenosis in these babies, and we don't know what erythromycin does to the gastrointestinal microflora. It probably does have an effect, but we don't know exactly what that effect is. Going down the gastrointestinal tract a little bit further, the gastrointestinal tract of our premature baby, because it's immature, has an absence of migrating motor complexes. In the term baby, who has a more mature gastrointestinal tract, you find that there is a very organized pattern of motor complex that goes aborally from the stomach all the way down to the rectum. Very nice migrating motor complexes, non-chaotic. When you start getting to the very premature baby, you start seeing chaotic movement. You see a little contraction here, a little contraction here. These are non-propulsive migrating motor complexes. That is a known immature pattern. And so what do we do for this? Well, one of the first things that we can do is simply just feed a baby. Studies have been done showing that putting some, at least small amounts of food into the gastrointestinal tract helps stimulate the motility response and maturation of the motility response. We know that in these babies it takes time for the food to be digested and to be absorbed, and it takes longer for these babies to stool. Passage of meconium is delayed in about 20% of these infants with birth weights less than 1,500 grams, according to one study. And a study that we did at the University of Florida showed that in some babies, meconium may actually be delayed up to 10 days in babies with birth weights less than 1,250 grams. Now, when we talk about absorption, digestion, and assimilation, we are talking about different processes. Digestion occurs in the lumen of the gastrointestinal tract. You have various enzymes and gastric acid that act upon the food in our gastrointestinal tract. That is the digestive process. The next process is the absorption, and that occurs at the enterocyte interface, okay, at the microvillus membrane. That's the absorptive process. And then the third process is assimilation, which takes the food into the bloodstream, and that's where it gets utilized for its various metabolic purposes. When we talk about protein, and I want to just talk a little bit about protein, carbohydrate, and lipids separately, the accretion rate of protein in the fetus is around 3.5 to 4 grams per kilo per day, and I know that Dr. Hay will be talking about this a little bit more. But if we were to try to feed a preterm baby with human milk, not the immediate human milk, not the colostrum, but human milk that is about a week to 2 weeks into the post-lactational or the lactational period, it would require around 330 milliliters per kilo per day of human milk to meet that requirement. And we are not able to feed babies that quantity of volume this early on. What about the capability of these preterm babies to digest protein? I'm not going to get into all of the individual steps, but I'd like to at least bring up a couple of them. And the first step has to do with what happens in the stomach. In the stomach of our preterm babies, we have a lower gastric acid output. And this is a study that was done in babies that were at 32 weeks gestational age, done several years ago. And here we see postnatal age in these 32-week gestation prematures, and this is acid output from the stomach. This is basal acid output, and this is with pentagastrin stimulation. Pentagastrin stimulates acid output from the stomach. And here we see in the first few weeks, there's actually very low gastric acid output in the stomach. So until about 3 to 4 weeks, you have a low gastric acid output, and that begins to plateau at around 3 to 4 weeks at a normal, mature gastric acid output. What does this mean? Well, with this low gastric acid output, if we do some things that might actually decrease this gastric output even more, we can cause damage to these babies. We can cause harm. A study that was done by Dr. Ronnie Gillette several years ago from Rochester, New York, looking at data from the neonatal network, evaluated babies who were getting H2 blockers. Remember, H2 blockers decrease the acid output from the stomach of these babies. And these babies already have a low gastric acid output. And what she found was that those babies who were getting the H2 blockers had a higher incidence of necrotizing enterocolitis. And there's also some other studies now showing that the use of H2 blockers is associated with more sepsis in these babies and a higher mortality. There's also another study, which was very interesting, that was done in Buffalo, New York, done in the early 1990s, where they took two groups of babies, and one group of babies received a formula that had some hydrochloric acid added to it. So they acidified that formula versus just a normal formula, and they found that those babies with acidified formula actually had a lower incidence of necrotizing enterocolitis. Very small study, but again, was very provocative from the standpoint of knowing about acid and the low acid output in these babies to begin with. Protein absorption. This is a physiologic process that even in preterm babies is fairly good. Single amino acids in preterm babies as well as adults are not absorbed very well. But we have transporters in our gastrointestinal tract that transport oligopeptides, 2 and 3 amino acid peptides, much better than the single amino acids. We also have an enzyme capability in our gastrointestinal tract that is involved with breaking down these oligopeptides within the intestinal epithelial cell, and these are quite mature in our preterm babies. Okay? So in our preterm babies, the absorption of amino acids and these oligopeptides is fairly mature even in the very preterm babies. So that's not that much of a problem, whereas the digestive component, as I mentioned before, is a potential problem. So in summary, partial and temporarily poor digestion occurs, but absorption is good in these babies. And could this immaturity in digestion be addressed by the use of protein hydrolysates? There are a couple of studies now looking at the use of protein hydrolysates, and I think the classic study was done by our colleague Walter Mihach in Germany. And Walter did these studies looking at hydrolyzed protein formula versus standard preterm infant formula in babies weighing less than 1,500 grams. And he found that the time from initiation of enteral feeds to full feeds was shortened with the hydrolyzed protein feeding, where there was about a 2-day difference in terms of initiation of full feeds to full enteral feeds. So these babies who were getting the hydrolyzed formula got to full feeds a little bit faster than the babies who were getting the full protein feeding. He did not have a human milk control. But if you look at some of the other studies showing the time to full enteral feedings with human milk, those studies show a much faster rate of getting to full feedings in general than with the use of formula. So still, if you have human milk available, that will probably get you to full feedings faster than either a hydrolyzed formula or a full protein formula. In the United States, we have not had a hydrolyzed formula for preterm babies that is specifically suited for preterm babies. I think that now there's one that's being introduced, but you have to be very careful with these hydrolyzed formulations for preterm babies because many of the hydrolyzed formulations do not have the calcium, phosphorus, and total quantity of protein that is actually required for preterm babies. Okay, now let's get back to this appropriate for gestational age 27-week premature baby, and how do we nourish this baby? Well, if we were going to give this baby full enteral feedings, which we can't do right away in most of our very low birth weight babies, that baby would grow if we gave this baby between 110 to 120 calories per kilogram per day if this baby was on full enteral feedings. If the baby is on TPN, no enteral feedings, positive nitrogen balance can be attained with around 60 calories per kilogram per day with about 2.5 grams per kilo per day of protein. What do we mean by positive nitrogen balance? We mean by positive nitrogen balance that the baby will actually be accreting protein, will not be breaking down his or her own protein. That would be considered negative nitrogen balance. If we want to get a baby to grow who is on TPN and no enteral feedings, we have to feed that baby by the parenteral route a minimum of approximately 80 calories per kilogram per day with a minimum of 2.5 grams per kilogram per day of protein. Can we reach 80 calories per kilogram per day? This was one of your questions. Can we reach 80 calories per kilogram per day if we are giving 3 grams per kilogram per day of protein, if we are giving that baby also 8 milligrams per kilogram per minute, and 1 gram per kilo per day of lipid? No. Because if we give that baby 1 gram per kilo per day of 3 grams per kilo per day of amino acid, that baby is getting about 30 calories from that, about 39 calories from that and the glucose, and baby is getting probably only about 15 calories from the lipid, okay? So that baby requires about 3 grams per kilo per day of lipid to actually reach 80 calories per kilo per day. You can do the math on that yourself. Can we feed this baby who has a UA catheter, a UV catheter in place, and this baby is getting prophylactic indomethacin? Can we feed this baby using the gastrointestinal tract? What are the consequences of feeding this baby, and how do we feed this baby? Well, first, if we do not put food into the gastrointestinal tract and only give TPN, there are some problems that we can incur. The longer we give TPN, the greater is the likelihood of this baby developing TPN-associated sepsis. Not only do we get sepsis from the lines, but there's also the likelihood of having translocation of bacteria from the gastrointestinal tract into the bloodstream. Why does this occur? This occurs because if you are not putting food into the gastrointestinal tract, you get atrophy of the gastrointestinal tract. If you do not put food into the lumen of the gastrointestinal tract, you do not get growth. And I'll talk a little bit more about that later. You have a lack of trophic hormones. You have a greater propensity for the systemic inflammatory response, decreased mucosal IgA from the Peyer's patches, and increased adhesion molecules and PMN, white blood cell attraction. So you have a greater likelihood of collateral damage. If you bring more white blood cells into an area, you have a greater propensity for inflammation. Okay? That all happens if you do not put food into the gastrointestinal tract and treat the baby with TPN alone. Here is what a liver looks like after 7 days of TPN versus enteral feedings in piglets. In this column, we see a piglet who is being fed by the enteral route. And in this column, we see a piglet that is being fed exclusively by the parenteral route, or IV route. Okay? You see quite a difference in the appearance of the liver. Histologically, here we are seeing ballooning of hepatocytes. We're seeing fat staining. And we're seeing glycogen staining. This is all evidence of damage to the liver in those animals. These are piglets who are getting TPN for 7 days versus enteral feedings for 7 days. We have some problems with the gastrointestinal barrier. And this is from a review article that we wrote several years ago looking at the intestinal barrier. And one of the things that happens if you have a breakdown of this intestinal barrier, you have a greater propensity for the translocation of the toxins that are in the gastrointestinal tract and also the bacteria that are in the gastrointestinal tract. And here we see increased likelihood of sepsis and systemic inflammatory response syndrome, necrotizing enterocolitis. Now, when you look at this in older children, there's also been an association with other diseases, type 1 diabetes, atopic diseases, and autism. That's older kids. But in the neonatal intensive care unit, we are very concerned about necrotizing enterocolitis, systemic inflammatory response, and late onset sepsis. This is a study from Dr. Cami Martin from England, from Boston, Harvard, Beth Israel Hospital, and she looked at the amount of feeding in her hospital, and this is highly representative of enteral feeding in many neonatal intensive care units. And again, this is a very sophisticated, very good neonatal intensive care unit. And in the purple here, we see the percent of babies on full enteral feedings. And this is, the blue is the percent still receiving at least partial parenteral nutrition. So at 7 days, very little enteral nutrition. Again, this very sophisticated hospital in the United States. Here we're seeing more enteral nutrition, and by 28 days, these very low extremely low birth weight babies are still not all on full enteral nutrition. Okay, this is very common. This is Dr. Elsie Widdowson, and she is very famous. She did some outstanding nutritional studies over 60 years ago. And I think this is very germane to what we're talking about here. And the studies she did 60 years ago was on suckled pigs, these baby pigs, and found that the suckled pig's duodenum gains 42% of its weight in the first 24 hours after birth. If that piglet does not suckle, that intestine does not grow. Okay, so this is one of the first studies showing how important it was to put food into the gastrointestinal tract to get intestinal growth. Those studies have been repeated many times over, and now we have these studies on minimal enteral nutrition. There are at least 12 studies showing that putting at least a little bit of food into the gastrointestinal tract doesn't have to be to nourish the entire body, but to nourish just the gastrointestinal tract has some benefits. If you put these studies together, you find improved feeding tolerance and growth, less need for phototherapy, decreased cholestasis, decreased osteopenia, gastrointestinal trophic hormone surges, improved motility, and no increase in complications such as necrotizing enterocolitis. In fact, there are some more recent studies looking at the lack of enteral feeding, not putting any food into the gastrointestinal tract early on, suggesting that those babies have a higher incidence of necrotizing enterocolitis. This is another study, again, done in piglets, and this was done at Baylor University. Very interesting study where they took a TPN solution, okay, the kind of a solution you would only give to babies intravenously. And what they did was feed these piglets different quantities by the intravenous route or by the enteral route, but the same formulation enterally versus parenterally. So they had different gradations of enteral intake of the same formulation. Here is 0 enteral intake, but 100% IV intake. 20% enteral, but 80% IV, all the way up to 100% enteral intake and 0 parenteral intake. Then they sacrificed these animals and looked at their gut growth. And here we see that between 20 to 40% of enteral intake, this is where you see the massive increase in intestinal DNA, protein, and weight of the intestine. Again, supporting Elsie Widdowson's studies. So we have this data in both animals and in humans that giving some food in the gastrointestinal tract is important in terms of just the growth of the intestine. Dr. Alan Lucas in the 1980s did some additional interesting studies where they looked at the hormonal surges with feeding. And in these premature babies that were studied in this particular publication, they looked at enteroglucagon, gastrin, gastric insulinotropic polypeptide, GIP, motilin, and neurotensin. And what they found at birth, just at baseline in these babies, this is before any kind of feeding was undertaken, was these particular levels of these hormones. At 6 days, if these babies were not fed, there was no response in these hormones, okay? No increase. This is no feeding. But if they put some food, small amount of food, into the gastrointestinal tract, minimal enteral nutrition, at 6 days, they saw a marked increase in all of these intestinal polypeptides. These are very important for gut growth and for intestinal motility. Now, I mentioned before the conundrum that we sometimes have with feeding babies who are getting indomethacin. And this is an interesting study also done in piglets at Baylor University, where they looked at superior mesenteric artery blood flow in an enterally fed versus parenterally fed situation. They started these piglets on enteral feeding, and here you see the superior mesenteric artery blood flow. And then they stopped the enteral feedings and put these baby animals on parenteral feedings, TPN, no enteral feeding. And you can see what happens to the mesenteric artery blood flow. It markedly decreases. What is the rationale for us to stop feedings when we are giving indomethacin to these babies? Well, the rationale that is commonly used is that indomethacin is going to decrease intestinal blood flow. Okay, so you give the indomethacin, you decrease the intestinal blood flow, you stop the feedings, you decrease the intestinal blood flow even more. So you make the situation worse, theoretically. Okay? Something to think about next time you stop feedings and give indomethacin. I don't think we've got the final answer to this. I know that Dr. Kleiman at University of California, San Francisco is undertaking a fairly large multi-center trial to look at this. They are not yet done with this study. They have not broken the code. But this is a study that is still being done in human premature babies to see if there is a problem with feeding and indomethacin. But I can tell you, I do not stop feedings when I give indomethacin to preterm babies, okay? Partially based on this. What about the intestinal barrier? The intestinal barrier is a fascinating tissue. We have at least 8 different types of epithelia in our intestine. And in the intestine, intestinal epithelial cells undergo mitosis in this crypt region. And then these cells, after they undergo mitosis in this crypt region or the stem cell region, most of the cells migrate up to the tip, where they are then extruded from the tip of the villus into the lumen of the intestine. That process in babies takes longer than in adults. It takes about 4 to 5 days for that process to occur in babies, where it takes about 36 hours for that process to occur in adults. We also have cells that migrate from this region to the very deep crypt region, and these cells undergo a differentiative process where they turn into a special cell type called the Paneth cell. These Paneth cells produce very important peptides that protect this particular region, the crypt region, from damage. We have different kinds of cells like the goblet cells. Goblet cells produce mucus, a slimy material that is protective for the gastrointestinal surface. This mucus also harbors the IgA, which is very protective. We have intestinal lymphocytes, very important for protection of the gastrointestinal tract. Then we have these cells called dendritic cells. Dendritic cells are fascinating because they live underneath the epithelium, and they shoot out these dendrites, these arm-like processes, into the gastrointestinal lumen, and they pick up antigens from the gastrointestinal lumen, bring them down to the subepithelial region, and then help the undifferentiated lymphocytes differentiate into regulatory or effector T cells. Very important for production of the adaptive immune system. So, very fascinating area, and I think that this is a great area for young neonatologists to get into now because it's, I think, a very rapidly emerging field. In these intestinal epithelial cells, we have the junctions between intestinal epithelial cells. And here's one epithelial cell, here's another, and the apical junction is called the tight junction. And that tight junction is made up of several proteins, occludin, claudin, and junctional adherens molecule. And these proteins attach to the intracellular proteins, the zonular occludins proteins, which in turn attach to actin filaments, and these act to open and close the intercellular space. When these proteins between the epithelial cells break down, you have the capability of antigens to permeate into the gastrointestinal tract. Okay? You develop something called a leaky gut or a hyperpermeable gut. This is not a good situation. What happens when you don't feed a preterm baby? Well, here we have a situation where preterm babies were studied by Drs. Schulman and Chandler. This was a study done in the late 1990s, where they gave preterm babies no enteral feedings for 14 days. And at that time, that was very, very common practice, not to put any food into the gastrointestinal tract for preterm babies for long periods of time. So they had one group that was not getting any enteral feedings, and another group that was getting what they called GI priming or minimal enteral feedings, starting at 4 days to day 14. And they gave these babies two different sugars, lactulose and mannitol, through their tubes, through their NG tubes. And lactulose and mannitol are two different carbohydrates that are absorbed in different ways. The lactulose only gets into the bloodstream if you have a breakdown of the intestinal barrier. So if you have the intestinal epithelial cells or the tight junctions breaking down, you get more lactulose into the bloodstream and therefore into the urine. This is a highly water-soluble molecule. And the higher the lactulose-mannitol ratio, the higher is the permeability of the intestine or the leakiness of the gastrointestinal tract. So what did they find? Those babies who were only getting TPN, seen in the blue here, no enteral feedings, had more permeability or a leakier gastrointestinal tract than those babies who were getting some enteral feedings, small enteral feedings. What are some of the factors that affect the tight junctions? Well, certainly, as I just showed you, enteral nutrient deprivation is one of them. The type and composition of feeding can be important. I'll show you a slide that shows that breast milk is different than formula. Stress. Our babies are very highly stressed. In fact, there are studies that show in animals that if you take baby rats and separate baby rats from their mothers for 3 hours a day for their first 7 days and compare those in adulthood to rats who were not separated from their mothers, there is increased intestinal permeability in adulthood in those rats who were separated from their mothers early on. We don't know if this happens in humans, but this is a very interesting phenomenon that we do see in rats. Cytokines, vascular endothelial growth factor, and some of the drugs that we give to babies affect the intestinal epithelial junctions. This is a study that was done at University of Michigan by a surgical research group headed by Dr. Barbara Wildhaber. And the question that was asked in this study was, is intestinal damage due to TPN itself or lack of enteral nutrition? And we commonly, as you saw yesterday, or you heard yesterday in the lectures, we think that a lot of our late onset sepsis comes through these indwelling lines. Well, we have some data here that suggests that a lot of these infections that we see do not just come through the indwelling lines. They can come through the gastrointestinal tract. This study took adult rats, 3 different groups of adult rats, one control group that was allowed access to normal feeding. There was another group that received TPN, no enteral feeding, and a third group that had a line in, but also had access to food. And then they looked at the culture, they cultured the organisms from the liver, spleen, and the mesenteric lymph nodes. In the control group, here's what they found in terms of microorganisms in the liver, spleen, and lymph node. Very few. In those animals who received TPN, they found a lot of translocation of microorganisms. But in those animals who had a line in, but were also allowed access to food, had very few microorganisms translocating. So that, again, suggests a protective effect of food in the gastrointestinal tract. And they surmised from this study that the major factor responsible for TPN-induced bacterial translocation is the lack of enteral feedings and not the administration of the TPN solution itself. Okay, we all know that, I don't think I have to say this to the audience here, that breastfeeding is best for these babies, but I think we need to really have a good understanding of several of the mechanisms involved with the composition of breast milk as well as the breastfeeding process itself and why it's important. And this is an interesting phenomena that relates to the permeability, the process that I just talked to you about. Question that was asked in this study was, what happens to the permeability of the gastrointestinal tract if you feed formula rather than human milk? And again, they used in this study the LM, or lactulose mannitol ratio. And here is study time 1, which was in the first week. And here is study time 2, which was a couple weeks later, and this is at about a month, and this is the composite. And here we see that any human milk was associated with very low lactulose mannitol in the urine, but formula was associated with high lactulose mannitol in the urine. This means that the lactulose was getting through the gastrointestinal tract because the gastrointestinal tract was leaky. Okay? So formula is associated with greater leakiness of the gastrointestinal tract than is human milk. The mechanism of that is not very well understood, but there's probably several different potential mechanisms. But I'd like to just mention one of these potential mechanisms. And the one mechanism has to do with lactose. And we have this myth that preterm babies are lactose intolerant. So the myth is that preterm babies are not able to absorb lactose. However, we do know that of any of the intakes that we provide to these babies, human milk seems to be very well tolerated, and also the lactose in human milk seems to be quite well absorbed. Studies that were done in the mid-1970s by Drs. Leuven and Intolerance at Boston Children's Hospital at Harvard University looked at this. And these were the first studies that suggested to us that there may be a problem with lactose intolerance or lactase activity in our preterm babies. And they were able to get small pieces of intestine from fetuses at various gestational ages. And they looked at these lactase activities, and in the very preterm baby or early fetuses, they saw very low lactase activities. And as the gestational age or the age of the baby increased, the lactase activity was also higher. At around 25 to 26 weeks gestation, the lactase activity in the intestine of these babies was only about 30% that at term, but the sucrase maltase activities was much higher. So this information got to the formula companies, and the formula companies decided that it would be a good idea to add things other than lactose to their formulas. So they started adding corn syrup solids, tapioca starches, and other hydrolyzed starches, for example, polykose. Well, again, we know that lactose seems to be fairly well tolerated by our preterm babies who are getting human milk. And studies have been done to look at what happens to lactose in the gastrointestinal tract in our babies. Even if the lactase activity is low, what happens with the unhydrolyzed lactose in the intestine is that unhydrolyzed lactose gets into the distal intestine. Bacteria act upon this, and they ferment the lactose. And the lactose actually provokes or promotes the production of some of these lactose fermenting bacteria, the bifidobacteria, for example, or the lactose fermenting bacteria. And what these bacteria do is break down the lactose into small, short-chain fatty acids, acetate, propionate, and butyrate. And these are very important for the gastrointestinal tract. In fact, butyrate is the most important fuel for colonocytes. It's not glucose, it's not glutamine, it is butyrate. With butyrate, we see increased proliferation, apoptosis, increased differentiation, and butyrate tightens junctions between epithelial cells. So giving this lactose may actually be a prebiotic. And here is just one study that was done in intestinal epithelial cells looking at transepithelial resistance. This is looking at the tightness between the intestinal epithelial cell. And here we see in the these cells that with butyrate, you have increased tightness of the intestinal epithelial junctions. So I'd like to just conclude here with just a couple of little points here. What about guidelines to continue, guidelines in our neonatal intensive care units? How many of you have written guidelines in your neonatal intensive care units? Guidelines for nutrition. Okay. Let's see, maybe a little bit less than half. Okay. Very important to have guidelines. Well, some of the guidelines that we use rely on gastric residuals. Okay. How good are gastric residuals in telling us how well a baby is doing? How many of you have, I'm not going to ask you to raise your hand, but how many of you have been called by a nurse in the middle of the night saying that we have this gastric residual of 3 milliliters here? Baby has not had these gastric residuals before. And 3 o'clock in the morning, you say, 3 milliliters of gastric residual. Let's stop feedings in this baby, and I'll just take a quick look at the baby, and we'll stop feedings. Okay. How good are these gastric residuals? Well, the studies that we have suggest that they are not very good at all. Okay? They are not very helpful at all. In fact, we have just started to do a study where we are randomizing babies to getting no gastric residuals measured versus gastric residuals measured. We have about 30 babies enrolled in the study. We're about halfway through looking at this, and we have not broken the code yet. But so far, it doesn't seem like not measuring gastric residuals has resulted in any problems in our babies. There are some indications to withhold feedings, certainly grossly bloody stools, ileus, pneumatosis intestinalis. Those are definite indications to withhold feedings in babies. But as far as gastric residuals by themselves, that is not necessarily an indication to withhold feedings. This is just an algorithm in our own neonatal intensive care unit. No way that I expect you to read this, but I can send this to you, or you can look at it on the web. And this just happens to be the algorithm that we have developed at the University of Florida for feeding our preterm babies. And I think that guidelines are very important, and we've shown that there are some studies showing that babies tend to grow faster and also have less problems such as necrotizing enterocolitis if you use feeding guidelines. So I'd like to summarize. The GI tract of the premature infant has several immaturities related to anatomy and function that do not allow for immediate introduction of full enteral feedings. And even if the baby is on intravenous nutrition, some enteral feeding, even if you only give small amounts, this would be recommended. Thank you.